Hello, this is your lesson on therapeutic drug monitoring, also often abbreviated as TDM. All right, for our introduction, let's talk about TDM measures blood levels of therapeutic drugs, of drugs that need to be monitored. And the reason we do therapeutic drug monitoring testing is to maintain the right amount of drug in the patient. If you have too little of the drug, there will be no therapeutic effect. And if you have too much, it can be toxic. And in addition to that, the response to drugs can be different in people. So not everybody handles drugs the same way. And a lot of that has to do with our genetic makeup and things going on with the liver. And we're going to get into all that. And so, and not all drugs have to be monitored, of course. But the ones that we do monitor, we monitor because it's very important to have the right level. So toxic drug monitoring uses the lab results gotten, the levels of drug, and also clinical information to select the best drug and dosage for the patient. Okay, so the drug's mechanism of action is its pharmacologic effect at its target area. For some drugs, mechanisms are unclear, and I found this out a few years ago. I didn't know this, but did you know that Tylenol, generic name acetaminophen, and for some of the international students, you may know it as paracetamol. This we actually don't know how it works. There's some theories out there as to how it works, but it's a drug that's on the market. It was approved a long time ago before the restrictions, that are from the FDA currently. And so, yeah, we know what it does. We know that it works, but we just don't know how it works exactly. And therapeutic drug monitoring assumes that the size of the pharmacologic effect is directly proportional to the amount of drug at the target level. So the more drug, the more pharmacological effect. And a therapeutic range, and therefore a drug that we monitor with therapeutic drug monitoring is going to be the low number is the minimum effective concentration, and then the high number of the range is the minimum toxic concentration. And so we want to keep the patient above that minimum effective concentration so that the drug has the right therapeutic effect for the patient, but we want it below the minimum toxic concentration because we don't want to make our patient sick. So the pharmacodynamics versus the pharmacokinetics. So the pharmacodynamics is the biochemical and physiological effect of the drug and their mechanism of action. So that it's usually been studied. You have a scientific basis. Maybe it's, binds to a receptor, or it prevents some reaction or something like that. So there's just all kinds. We're going to get into more specifics later. And so the dynamics is its biochemical and physiological effect at the target site. And it, of course, is related to its mechanism of action. Now, pharmacokinetics have to do with, if you will, how the drug moves through the body. So the rate of absorption, the rate of distribution, biotransformation, and excretion of the drugs. So, and a lot of factors can affect the pharmacokinetics because they are dependent on the person taking the drug. So some of the factors that can affect the pharmacokinetics of a drug are, for example, the patient's history and other drugs that they might be taking. So some drugs may interact with other drugs. Patient's history, for example, did have a history of renal issues, liver issues, or stuff like that. Okay. How the drug is absorbed. And so some of that is, so let's say, we're going to, again, get into that a little bit more, but if it's one that's ingested, what if your patient, for example, has an inflammatory bowel condition that is impeding absorption of nutrients and drugs. Okay, so that, that could play in. How it's distributed, so how it circulates throughout. What if there are problems within the circulation that can keep the drugs from reaching certain areas? How it's metabolized. So drug metabolism is usually liver dependent, and so liver function can vary in patients. We'll look at some of that. How it's cleared from the livers and biotransformed. So is it made water soluble and enters the bloodstream and is excreted in the kidneys, or is it maybe excreted in the bowel and then pooped out? I mean, yeah, and then of course, how is it excreted? Does it leave, or even in the excretion, it could be, is it sweated out or something? Okay, so this little graph has all of it together. So the pharmacokinetics and the pharmacodynamics. Again, the kinetics is how it moves through the patient, right? So what dose is the patient on, and then the dose administered is going to determine the bioavailability, and within the circulation, within the tissue, and then that's part of that is distribution, it going, in the circulation into the tissues. And then from the circulation to the, metabolism or excretion, and that's the drug's clearance. But, in part of it in the circulation is going to, reach target tissues. So the drug effect at the site, it's its pharmacodynamics. So what is its pharmacologic effect? And if there's too much of the drug, you can have a toxicity. But normally you would have, if let's say that enough of the drug reaches, you would have the effect intended that the drug has, and you have a specific clinical response and a clinical utility. So, so there you go. If you took an example for, let's just take for example, ibuprofen. So if you take a regular dose, you should be able to swallow it. It should be absorbed. It may take 30 minutes to 45 minutes for it to be absorbed and start entering your circulation and reaching the tissue. So maybe you're taking it for a headache or something, so it takes a little bit before it can reach up here where it helps your head. And then the liver is going to start clearing it out little by little. Usually your typical doses of ibuprofen are every 6 to 8 hours, so that's probably about as long as it takes to metabolize and excrete it. And then at its the pharmacological effect, it's an NSAID, so it's a CoX enzyme inhibitor. And so it prevents the formation of prostaglandins. And so this one is hard to get toxicity, although you can take too much, but normally you would just have straight up the efficacy. So it is actually working, blocking prostaglandins and stuff, and it's relieving your headache. And that's the clinical response the clinical response is it blocks the prostaglandins, which then decrease the symptoms, and that gives it its clinical utility as, oh, you took it for a headache or from some inflammation or something like that, and it had the effect intended. Okay, so let's talk absorption. So a lot of drugs are administered orally, so you can just take them as a pill, a tablet, or something, and just swallow them, or they could be a liquid, right? And so the idea is that they will dissolve in the GI tract. And the site of absorption for most drugs is the same as the site of absorption for the nutrients, and that would be your small intestine. Or there's certain drugs, some things can be absorbed in the stomach. Others, the majority of them is going to be in the small intestines. And so from the small intestines, then they will enter the hepatic portal circulation. So the portal circulation connects your intestines to your liver and via the hepatic portal vein. So everything that is absorbed by your intestines goes straight to your liver. And so the drug that you just took, we could continue, for example, with ibuprofen. The ibuprofen you swallowed is first going to make a what we call a first pass through the liver. And the liver is going to start metabolizing. So it's actually going to start trying to remove it from the system. But then part of it does enter into the systemic circulation. And, that would be your blood supply. And, then it circulates throughout your body. And if the drug is such that it is completely cleared through first pass, then it's going to be a drug that you just can't give orally, because you cannot get therapeutic levels, you cannot get good levels into the systemic circulation to go to the tissue and have an effect. Sometimes those drugs then are given in a different way. So like maybe an IV or an IM. IV is intravenous, IM is intramuscular. So the absorption rate is influenced by several things, by the drug formula. So is it a quick release, extended release? Is it in a capsule, in a tablet? Is it in a liquid? All of that. GI motility. So how fast are things moving through your system? Does your system move really slow? Are you constipated a lot or something like that? Or maybe you have an episode of diarrhea and things are just moving really, really fast through your system. Okay. Any GI diseases. So if you have, if the patient has conditions like Crohn's, ulcerative colitis, irritable bowel, and all of those things, celiac, food sensitivities, all of that, anything that can increase inflammation in the intestines is going to it'll interfere with the absorption of the drug in the GI tract. And then there are certain foods. And so we're going to talk about grapefruit, because grapefruit is actually something that can interfere with drugs. So in your Blackboard class, there's a folder of stuff that I normally hand out, and there's a pamphlet on foods that affect drugs and grapefruit more especially. But I'm going to show you this graphic from it. You're welcome to go in there and find it to get a full information on it. So basically, this is what's going on. When drugs are swallowed, they may be broken down by enzymes and or absorbed using transporters on the membranes and cells in the small intestine. So that means it would bind on the transporter, and then it brings it into the enterocyte, and then it brings it into the circulation. Okay. Grapefruit juice can cause problems with the enzymes or the transporters, causing either too much or too little of the drug in the body. So you would take a proper dose of the drug, and you are taking it with some grapefruit juice, because that's what you have in your fridge. And the grapefruit juice is going to block the enzyme that normally clears the drug, and you'll end up with too much drug in the body. So statins are one of them that does that. So statins are used to lower cholesterol, and they're not a TDM, but they are broken down by enzymes. There's some of the CYP450 enzymes in the liver, and grapefruit juice can block the action of those enzymes that are specifically detoxifying the statins, and that increases the amount of the drug in the body and can cause more side effects. And so statins can have some nasty side effects, but even more so if you're taking it with grapefruit. Again, on another one, a proper dose like Allegra, it used to treat allergies, is now over the counter. Allegra is moved by transporters into the body cells, so it needs those transporters to be absorbed and then to go have the effect. But the grapefruit juice can block the action of these transporters, which then decrease the amount of drug in the body and can also cause the drug to not work well. Anyway, so this is something that's super important to know, and that's why sometimes there are some recommendations to not use grapefruit juice. Now, the funny thing is, this is fine for, like, you could take orange juice. Orange juice would be fine. Just there's some components of grapefruit juice that are, interfere with drug absorptions. Okay, so then that brings us to bioavailability, and obviously grapefruit juice can affect the bioavailability of certain drugs. But so the term bioavailability refers to the fraction of the dose that you've swallowed that actually reaches systemic circulation. So for orally administered drug, the bioavailability is always less than 100% because of first pass metabolism. And it also depends on the formulation of the drug. Is it an immediate release or a sustained release? So is it meant to get into your system and peak and then go down, or is it meant to just slowly release into your system? Okay, so all of that can affect the bioavailability, or how much of the drug enters your systemic circulation at one time. And this is less of a factor for IV drugs, intravenous drug, or inhaled drugs, because their bioavailability is usually 100%. Obviously, if you're putting the drug straight into the systemic circulation, the bioavailability is going to be pretty high. Although even drugs that are going into the systemic circulation, that blood does circle eventually through the liver, and the liver is going to start clearing it. But pretty much, at least what's put in has at least one go around where it is 100%. And inhaled drugs, if you think about it, like think of inhaler or something like that. So it goes straight into your lungs, and then the lungs have an interface with capillaries. So it goes from the lungs straight into the capillaries, then it circulates, and then it goes to your liver to start being processed. So the distribution is the process of moving a drug from the site of absorption to other areas of the body. The dosage is important to distribution and bioavailability, and so a lot of times the dosage is per kilogram of body weight. So you would give a smaller dose to a smaller person and a bigger dose to a larger person. It can also be a factor of receptor availability, whether that receptor gets it, if it's an orally administered drug from the small intestine into the circulation, so through the intestinal wall, or whether that receptor allows it to bind to certain tissues and enter the cells and all of that. So that could, and receptor availability can vary between people. The free drug is what is freely floating in the circulation, and it is available for distribution. So it can go bind to the receptors, enter the cells, and all of that. And that is the active drug. And there are some TDMs where you can get the free drug levels, but free drug testing is usually limited, and we usually do total levels of the drugs, which would be a combine of the free drug and then the bound drug. So the bound drug is drugs tend to bind to proteins. Proteins carry stuff, and so you do have to, all that's factored into the dosage. If the drug is bound to protein, it's not free, so it can't have an effect. It would have to unbind and be able to go bind on the receptor or whatever. So your acidic drugs tend to bind to albumin, and your alkaline drugs tend to bind to your globulins. And diseases and physiological changes can affect the distribution. So again, we talked about the GI diseases, but even like cardiovascular disease, things if you have like congestive heart failure, so your heart's not pumping right, or you have problems with your circulation. There's just so many things that can affect distribution. So things that affect, for sure, the cardiovascular system and the GI system can affect distribution. The distribution in the brain and spinal cord is contingent on it getting around the blood-brain barrier. And the blood-brain barrier is such that there are many drugs that cannot cross it. And it's a safety measure for our brain, because our brain can be, harmed by some of these. So some drugs can cross the blood-brain barrier, and some drugs cannot cross the blood-brain barrier. All right, so metabolism and biotransformation. So the liver is the organ that metabolizes drugs, and the variation in a person's genetics related to drug metabolism is known as pharmacogenomics, and this is an exploding, growing field. And it's concerned with predicting how individuals will respond to drug. And what they do is, so they get their genomic profile of the enzymes that they have that they can code for, so that they know, and how much of them they produce and all of that, so that they know how they will metabolize a certain drug. So it is limited testing right now, so it's definitely something that's being developed and grown. And Coumadin testing is one that is currently available. So that is in blood thinner, so an anticoagulant. So that would be the coag testing, really. But it is possible to get a pharmacogenomics on Coumadin for a patient to see if the patient is a slow metabolizer, a fast metabolizer, or a normal metabolizer of Coumadin. And then that might affect their dosage and whether even the frequency of taking the drug. And then, so biotransformation is a conversion of potentially harmful chemicals into inactive metabolites. So you have to also realize that these drugs that we take in, even though they do have pharmacological effects on us, and that's why we take them, really don't, they're not normally part of our body, and they don't serve a natural function. And so your body sees them as toxic and they need to be gotten rid of. And so, and the way it gets rid of them is it biotransforms them by inactivating them, turning them into inactive metabolites. So, in liver drug metabolism, you have first order kinetics and zero order kinetics. First order is linear, zero order is nonlinear. And if you remember our enzymes chapter way back towards the beginning of the semester, it's enzyme kinetics are the same. So these are simply, when we're talking about drugs, we're talking about the enzymes that metabolize drugs. That's it. But the concepts are the same. So again, the curve, if it goes straight, is linear like that. And basically, the more substrate you have, the faster the enzyme works, right? It goes up, and then at one point in time, it levels off, and then it's flat. Curve is flat, and then that zero order kinetics is nonlinear. Then that one, the rate of metabolism is independent of the drug concentration. So a lot of drugs are cleared in first order kinetics. So the metabolism of the drug is proportional to the drug concentration, and the drug elimination is adaptable. So you have a little bit of the drug in, it'll eliminate it, probably a little bit slower, but it'll eliminate. If you have a lot, it'll eliminate it faster. 95% of the drugs fall in this first order kinetic of drug metabolism. In zero order kinetic, which is nonlinear, there are a few. Alcohol is one of them, and phenytoin is another one. And it basically, the amount of alcohol that you ingest does not increase the speed of metabolism by the liver. And so basically what it means, if you're drinking a lot of alcohol, the more alcohol you drink, the longer it will take you to clear it from your body, because it's not going to clear it any faster the more you ingest. And so it'll just take you longer. You have a longer hangover, if you will. All right, so the enzymes that do this biotransformation and metabolism in the liver are of the family of the cytochrome P450, the CYP enzyme family. There are a bunch of them, and they have other numbers associated with them, and they clear most of your drugs. And you can look at genetic profiles for this cytochrome P450 do vary in people. And so how many of those you have and which ones you have can affect several things. So as they clear drugs, maybe it's the same enzyme that can clear two different drugs, and both of those drugs will compete for binding. And so it could potentially result in drug-drug interactions and either slow or boost the metabolism of a second drug, because they're both being processed by the same specific CYP enzyme. It can affect also the food-drug interactions. So, for example, alcohol, even though alcohol is not technically food, but it's part of our food supply, I guess, it can compete with drugs for metabolism, and so that's why there's warnings on a lot of drugs to not consume with alcohol, because that could slow its metabolism and its clearance from the body, because they're being detoxified by the same enzyme. The same enzyme that detoxifies the alcohol would detoxify that specific drug. A few drugs have to pass through the liver to be converted to their active form. So basically, the drug that you take does not have an pharmacological effect until the liver has done biotransformation. So one of its metabolites is what has the metabolic effect. So procainamide is one of those, and it turns into NAPA, and NAPA is the molecule that has the actual pharmacological effect. And then, of course, you have excretion. You have to it has to leave our body. Again, our body sees all of these as foreign substances that need to leave. So some drugs are completely cleared by the liver, right? And the clearance factors are the free drug concentration, which is related to the dose and how much got absorbed and all that. The hepatic function, how well the liver is working. Enzyme inducers and enzyme inhibitors. Enzyme inducers would speed it up. Enzyme inhibitors would slow it down. So those are all clearance factors, but after metabolism, the metabolites are excreted. The water-soluble ones will be excreted by the kidney. So basically, once the liver has biotransformed it into a water-soluble molecule, it can enter the circulation again and then travel to the kidneys, and then the kidneys would excrete them in tubular secretion, and it will enter the urine. And for the lipid-soluble ones, they would just enter bile, along with cholesterol and other things. And then as you eat, bile is dumped into the GI tract, and of course it exits with feces out. Some volatile compounds can exit via the lungs. Alcohol is definitely one of those. That's why they can give breathalyzer test, because you're metabolizing and some of it is coming out on your breath. It is also worth noting that drugs can also enter and be excreted into breast milk, and they can affect the baby. All right, so what are different ways we can administer drugs? And so the route of administration will affect the concentration and the dosage given of the drug and its effect and all of that. So oral route is probably one of the most common, because the oral route is sold, over the counter, plus, the majority of medications that are given that patients can self-administer or come in via the oral route. So that's simply swallowing them, and again, pill, tablet, liquids, whatever. Those are the oral route. Now, intravenous route is the fastest has the fastest action. So that's you have to have an intravenous line. And so most of those are administered under the supervision of medical professionals like nurses, usually in a hospital or clinic setting, but sometimes in a home health setting also. And then we have intramuscular routes. So usually those are, again, given by healthcare professionals, nurses, and they're injected in muscles, arm, buttocks, or something like that. And they, get a shot, and there you go. Maybe you get a shot on a regular basis, for example, a vitamin B12 shot, and they last for a while. It is possible, if you're trained, that you can do your own IM injections. So that is totally possible. Other routes that drugs can be administered, suppository. So that is actually a really good way to administer some drugs that would exist in oral form, not IV and IM, but let's say maybe the patient is got a tube down their throat, they're intubated or something like that, and or there's something wrong with their stomach, and they can't absorb, and so they cannot take anything orally. And there are drugs that don't have an IV or an IM thing. For example, Tylenol. Tylenol, you can only give it orally, except there are also Tylenol suppositories. So in a patient like that, you might have to, they might have to get a Tylenol suppository. So suppositories can be also, and they go up the anal canal, so they go up in the butt. And they also can be very helpful. There are things like Phenergan suppositories and stuff, which could be helpful if you are throwing up so much you can't keep anything down and you can't take a pill. So inhalation, so like some of the asthma inhalers and stuff like that, or breathing treatments and stuff, going straight into the lungs, and from the lungs they go straight into the circulation. Intraperitoneal, so injected into the peritoneal cavity. Or topical, so something like that could be simply a topical antibiotic, or it could be for example, nitroglycerin, something that's given topical. So they give a certain length on a piece of paper and then apply it to the chest of the patient, and then it diffuses slowly into the microcirculation, into the circulation. So, but like, let's say topical antibiotics, anti-itch creams, those things like that. Switching to different forms can also limit exposure of the same area of the body to reduce the effects. For topical, for example, I've seen them do that. Let's say birth control pill patches, birth control patches, or stop smoking patches, you also want to move those around the body and not always apply it to the same area. If you give an injection, you want to, like I am, you usually want to just rotate if it's something that's regular, not always give them at the same site. Okay, so the drug levels. The drug concentration determines the effectiveness of the drug. So what the goal is in the TDM drugs is to achieve therapeutic range. So again, above that minimum effective, below that minimum toxic. A subtherapeutic dose may not provide the necessary amount to, for example, clear an infection or resolve a seizure, but then too much could lead to toxicity and be toxic to the liver or the kidneys and can cause organ damage. So we don't want to do that either. Antiepileptic drugs can cause seizures if the dose is too low or too high. So they have that, again, that therapeutic range there that you have to be in. Some drugs will require a good loading dose. One of the ones I can think of right off the bat is heparin. So if a patient has a blood clot and they want to give them some heparin, which they would monitor with PT-PTT, they will give them a big bolus of heparin to kind of get things going, and then they will do a drip that's based on their size and all of that. And so the loading dose is that big bolus, that bigger dose at the beginning could be sometimes via a shot if this is something that can give an IV or IM, and it will help reach therapeutic concentrations quickly. So there's a good benefit to that. And then, but that you usually only do it, like I said, at the beginning, and then you switch to the maintenance dose is much lower than the loading dose, but then it's a steady level. And that could be, that can depend on the type of drug. So maybe it's something you take every 12 hours, morning and night, or maybe it's something you take once a day, or maybe it's something you have to take every 6 hours, 3 times a day, but it's the same dose, and that allows you to maintain a steady level. The steady state is the amount of drug that enters you have reached steady state when the amount of drug that enters the body is equal to the amount of drug leaving the body, and so you are kind of just like at the steady therapeutic dose. And it's not actually a straight line; it's more of like up and down. But the up and down, as the dose enters and then it's excreted, enters is excreted, is in that therapeutic range. It stays in there. The half-life of a drug is the rate at which the drug is cleared from the body, and it's the time for the concentration to decrease by half. And you can get an idea of the half-life of a drug by the timing of its dosage. So, for example, a drug like we talked about earlier, like Allegra, that's an allergy medication that is taken once a day, so it has a 24-hour dosage, would probably, take about a day or so to reach its half-life, or maybe less than a day to reach its half-life because it will be dropping. So there are other drugs, for example, let's say Benadryl, you can take every 4 to 6 hours. So it reaches its half-life way faster than, for example, Allegra. So those are just 2 examples. So the shorter the interval between the doses, the shorter the half-life, basically. And then the therapeutic range, again, is the range at which the drug effectively treats the disease with a minimum amount of toxicity. Okay, let's talk a little bit about sample collection. So the single most important factor in therapeutic drug monitoring is proper specimen collection. I cannot emphasize that enough. And this requires actually a good partnership between the lab and the nursing staff, because the nursing staff are administering the drugs and the lab is drawing the levels. So first, of course, on the part of the lab, you have to have the proper collection tubes. So some drugs require serum, some will require plasma, some could be either. In some drugs, you can use a serum separator tube. So that's the tube with that gel that helps pull the plasma off the cells. And then some of them, you can't, because actually the drug gets trapped in the serum separator tube gel, and then it would lead to falsely decreased levels. So it's very important to be aware of the type of tube needed and to collect it. Now, nowadays, it is nice because it will print on the collection labels the tube that you need to collect. And so just be aware that it can make a difference in the results, and that you should respect what is on that label. And usually it's not a good idea to interchange samples. So your peak and trough collections, so if you think about it this way, the peak of a mountain is going to be the highest level the drug is at, and then the trough is like the valley, it's going to be the lowest. And so most drugs, CDMs, will use trough specimens, so the lowest level, and it's usually right before the administration of the next dose. And your therapeutic ranges are based on the trough levels. And so as long as the lowest level is not toxic and it's still within the therapeutic, then we're good to give the next dose. And antibiotics typically use a peak and a trough collection, although some institutions have gone to trough only, levels. So basically the idea is that you would draw a trough level before the dose is given, and then the nurse would give the dose of the medication. And then if, for example, if usually the rule is if the drug is administered over 30 minutes, you wait 30 minutes and then you draw. If the drug is administered over 60 minutes, you wait 60 minutes for the IV and then draw it. And if it's an IM dose, you have to wait 60 minutes and 2 hours after an oral dose. And so the idea is the peak would be trying to catch that highest level as it has absorbed. Okay, that would be a peak level. So this is where, again, it's really important to collaborate with nursing staff, because what if they were supposed to give a drug at noon, run it over, let's say it's an IV drug, run it over 30 minutes, and then wait 30 minutes, and then you have a 1 o'clock peak of that drug scheduled. And that's how it's scheduled. That's how it's supposed to happen for the patients. But something happens with maybe one of the other patients that the nurse is taking care of, and she's delayed, and she doesn't start hang that drug until 12:15 or even 12:30. And you draw your peak at 1 o'clock, it's going to mess up. The timing is messed up on that. So she should have the presence of mind of calling you and say, hey, can you delay it and collect it at X amount of time because I couldn't hang it right away. And if you collect the samples, or if the phlebotomist collects samples, then it's good to look to make sure that, one, the drug is completely infused before you draw it. And it's always good to check with the nursing staff before you actually stick a patient, because they're not going to be happy if you have to stick them again, just like 15, 30 minutes later or something like that, because, the timing was messed up. So things that can affect drug distribution. So aging has an effect on drug distribution, and pregnancy. So let's talk about aging. So as patients age, their GI function decreases, so less of the drug is absorbed. They have reduced body fluids, as in they are basically chronically dehydrated, and so that could increase the plasma concentrations. And they have a reduced ability to clear drugs, which also can increase the plasma concentration of drugs because their liver is not working as efficiently as it did when they were younger. And pregnancy, so nausea may affect absorption. So if the pregnant lady is, having a lot of nausea, maybe throwing up and stuff like that, that could affect the absorption. A pregnant woman has an increased plasma volume, and so that would dilute the drug more and lead to lower concentrations of the drug. And her liver's working overtime, and they will actually cause a faster removal of drugs and therefore lower concentrations also. And then you also have, of course, placental transfer, which is very important for teratogenic drugs. So those are drugs that can cause, some problems with the fetus. They can cause birth defects, things to be malformed. It can even cause miscarriages and stuff like that. So these are the drugs that you cannot take while you're pregnant. For example, I know the bipolar drugs are teratogenic. So one of my oldest daughter's friends was pregnant, and she was bipolar, and she had to be, as soon as they found out she was pregnant, she had to be off of her medication the entirety of the pregnancy. She got back on them afterwards, but yeah, in the meantime, because they were teratogenic, it was a threat. It was a threat to the baby. All right, so let's look at this one, Marisa's case. So Marisa is 15, and she was brought to the ER with severe shortness of breath. She has a history of asthma. She has been using her rescue inhaler, but it is not helping her to breathe any easier. The ER physician administers theophylline intravenously to open up her airways. After about an hour, the patient begins to feel better, but she then becomes nauseated and vomits. She continues vomiting as the physician comes in to re-examine her, and he orders a theophylline level and a metabolic panel. And so the results show a theophylline level of 30 micrograms per DL, and the range is 10 to 20 micrograms per DL. So it's obviously too high. The calcium is 7.9 and the potassium is 2.9, and those are both lower than what they should be. And so what condition is revealed by these test results? We'll have to answer that in the Nearpod. And why did the physician choose to treat her with theophylline? So just look up or think about the difference. We're going to look at some of this here in a minute between the rescue inhaler and the theophylline. All right, so let's get into specific drugs. So some of the drugs that we do monitor, again, we do not monitor everything that's on the market. We literally monitor a fraction of what is on the market. Okay, so we're going to look at the cardiovascular drugs first. They are used to treat arrhythmias. Many affect the sodium-potassium pump, or they will affect the sodium channels or the calcium channels. Digoxin and amiodarone are frequently ordered therapeutic drug levels that are cardiovascular drugs. Quinidine and procainamide are infrequently ordered. You will not see those very often. You'll see them some, but just not very often. Procainamide testing also has to include its metabolite, NAPA, and acetylprocainamide, because that is the active metabolite and will affect the therapeutic range. So they always go in tandem. Again, not all drugs given to patients can be monitored. So, for example, both propranolol and verapamil are not available for testing by major reference labs. All right, now the cardiovascular drugs. So we have digoxin. This is from the plant, the foxglove plant. Too much of it can be fatal, and because that is a poison, really. And it targets the sodium-potassium pump. It lowers your heart rate. It treats atrial flutter or atrial fibrillation. And it treats heart failure, or it's a treatment for heart failure. You can't reverse heart failure, but it's one of those maintenance drugs. The therapeutic range is 0.5 to 2.0 micrograms per liter, which is a very small and narrow therapeutic range. And if the patient has too much, you will see GI and cardiac symptoms of toxicity. All right, lidocaine. This is another one. It's actually a local anesthetic, but it's also an antiarrhythmic. So they can actually infuse lidocaine, as in like in an IV bag, right? It is often used after an acute MI to prevent ventricular arrhythmias. It is a sodium channel target, and an overdose can cause a central nervous system depression. So think about it, it's an anesthetic, right? So too much of it would make you anesthetized, basically, right? So quinidine treats ventricular arrhythmias, limits sodium ion influx, and can be used to treat malaria too. Toxicity, it will manifest as vertigo, tinnitus, which is ringing in the ears, headache, and low blood pressure. Procainamide treats ventricular arrhythmias too. It is also a sodium channel blocker. Its therapeutic window is again kind of narrow, 4 to 8 milligrams per DL, and it's toxic at greater than 12, and it will depress heart activity. Then we have disopyramide, or pyramide, maybe pyramide. Similar to quinidine, it blocks sodium channels. At high doses, it can inhibit neurons because they also need sodium channels, and it can cause hypotension and it can cause congestive heart failure. That's not really good there. Flecainide is another sodium channel blocker. It is toxic to acute MI patients, has a very narrow therapeutic range, and toxicity will depress the heart, so you get hypotension and bradycardia. So it'll make it not work hardly at all. Propranolol is a beta blocker, and it affects the heart muscle, and it opposes adrenaline. So adrenaline gets the heart pumping and going and gets your heart beating fast, right? So it blocks that, has the opposite effect of that, and it lowers heart rate. And toxicity would cause bradycardia, hypotension, and cardiac failure. So again, propranolol is one of those that's not often ordered, but could be potentially checked. So amiodarone is a thyroid hormone analog. It blocks potassium channels in the heart. It is used in advanced cardiac life support, that's what ACLS is, for pulseless VFib or VTAC. So it's ventricular fibrillation or ventricular tachycardia with no pulse. The therapeutic range is 0.5 to 2.0 milligrams per DL, and it has many toxic effects. And then the last one is verapamil, and it blocks calcium channels in the AV node. So that's part of the electrical system in the heart. It treats angina, which is chest pain, hypertension, arrhythmias, in the toxicity, you will see hypotension and ventricular fibrillation. Okay, so let's move to the antibiotics. Some antibiotics are associated with severe side effects, and therefore we have to monitor their therapeutic levels. The common side effects of antibiotics that have toxicity are nephrotoxicity, so they're toxic to the kidneys, and ototoxicity to the ears. And for the ears, what it can cause is loss of hearing all the way up to total deafness. Chloramphenicol side effect is toxicity to the bone marrow, so that would cause low production of your blood cells, which is not good if you think about for an antibiotic, right? These drugs are typically drawn as trough and peak levels, although again, some institutions have gone to trough levels only. And again, in order to properly dose the patients, these levels have to be drawn correctly. So you have to draw the trough before the dose. You can't be late. You can't be drawing it after they've hung the dose. And then you have to draw the peak level at the correct interval after the dose is finished infusing. So again, proper collaboration with the nursing staff is really important. Antibiotics can be bacteriostatic or bactericidal. Bacteriostatic, again, means that they stop the growth of the bacteria without killing them, which does allow the immune system to get the upper hand. Bactericidal is they actually right out kill the bacteria. Some antibiotics are broad spectrum, which means they have a wide range of activity against, they have a range of activity against a wide array of bacteria, gram-positive, gram-negatives, and stuff like that. Some are narrow spectrum, but sometimes are required for it. You just have to know what specific bacteria you have. So narrow spectrum means it's usually one typical type of bacteria that it is active against. Again, all of these drugs have to be used judiciously also in an effort to prevent antibiotic resistance, and that's a whole other topic. All right, so the majority of the antibiotics that have to be monitored are your aminoglycosides. They bind to bacterial ribosomes, which are different from our ribosomes, and interfere then with protein production. And so they are usually given IV or IM. So we have amikacin is given every 12 hours. It's nephrotoxic, ototoxic with prolonged use. Gentamicin is every 8 hours. It's nephrotoxic, ototoxic with prolonged use. Also, kanamycin is oral. Also, it's IVIM or oral, and it's nephrotoxic, ototoxic with prolonged use also. And tobramycin is nephrotoxic, ototoxic, and neurotoxic. Vancomycin, which inhibits cell wall synthesis and treats MRSA, can cause vancomycin-resistant enterococcus infections, usually in the gut, and it is ototoxic and nephrotoxic also. And chloramphenicol can cross the placenta and the blood-brain barrier, and this one is toxic to the bone marrow. All right, so moving to the anti-epileptic drugs. So those are anticonvulsants, so they are used to treat seizures. Most anti-epileptics block sodium influx into the neurons, the neurons that have damaged membranes. Numerous anti-epileptic drugs are available, and many patients have to take multiple drugs to control their seizures. Many of these drugs will require a specimen to be sent to a reference lab to be analyzed, but there are some that are commonly analyzed in the lab. Phenytoin, carbamazepine, and valproic acid are three very commonly available in your regular lab, on your normal clinical chemistry or immunoassay analyzer. Your phenobarbital is a barbiturate. It is a sedative. It binds to the GABA receptors in the central nervous system. It is used for anxiety and sleep, and you can develop tolerance and dependence. So tolerance is where you would start needing higher and higher dose to have the same therapeutic effect, and dependence is where you would need it to function. So for example, since it can be used for sleep, somebody that develops dependence has to have the phenobarbital in order to sleep, or they can't sleep. Okay. With toxicity, you see CNS depression. So if they take too much of it, they may be hard to wake up. So phenytoin is dilantin. It is important for you to know both names, that phenytoin is dilantin, because you will have it, usually we have the generic name, so we have phenytoin in the lab, but the nurses know usually the brand name, they know it as dilantin, and so they may call you and say, hey, where's my dilantin level, and you have to know that they're asking about the phenytoin. So there you go. So learn those. It inhibits the sodium channel. It is not a sedative, but the toxicity will cause central nervous system depression. Valproic acid is known as Depakote or Depakine. It inhibits the GABA receptor, GABA transaminase, and an overdose will lead to coma. Carbamazepine, also known as Tegretol, keeps the voltage-gated sodium channels inactive. With mild toxicity, you see vomiting and ataxia. Ataxia is like lack of coordination. In severe toxicity, you will see seizures and respiratory depression. They may just quit breathing on you. And etosuximide is a calcium channel blocker, and when you have toxic levels, you will see nausea, vomiting, and even coma. Primidone metabolizes into phenobarbital and binds the GABA receptors in the central nervous system. Clonazepam or Klonopin is a benzodiazepine. It's related to Valium, which is diazepam, and it treats panic disorders or anxiety, if you will. Gabapentin is also known as Neurontin. It's a chemical analog of GABA, so it's going to kind of chill people, right? Lamotrigine is a GABA antagonist. And then Keppra or levetiracetam has an unknown mechanism. Here's one of those, we don't know how it works, we just know that it does. And its toxic effect will decrease your red cell count and your hematocrit in your neutrophils. And then oxcarbazepine blocks sodium ion channels, and the toxicity is hyponatremia. And then you have your psychoactive drugs. So you have lithium. Lithium treats bipolar disorders. Lithium testing is available in many clinical laboratories. You usually do ion selective electrode or immunoassay, immunometric type of method, commonly done. And then you have your TCAs, tricyclic antidepressants. So they're often, if you have to assess them, they'll be done by high performance liquid chromatography or liquid chromatography in tandem mass spec, and usually sent to a reference lab, obviously. Testing for amitriptyline will include a measurement for nortriptyline. So most tricyclic antidepressants are norepinephrine and serotonin reuptake inhibitors. And some of them are amitriptyline, also known as Elavil, nortriptyline, desipramine for ADHD, imipramine, and diazepam, which is Valium, which is a benzo, treats anxiety, insomnia, and modulates GABA transmissions. And then you have your bronchodilators. So the bronchodilators target the lungs. Theophylline is the one. That's it. This is the only one. It is used infrequently in adults today, but is used extensively in infants with apnea. In order to monitor the effectiveness of theophylline in infants, caffeine levels are measured, and because caffeine is an active metabolite of theophylline. It is a sympathomimetic, so it is a bronchodilator that does not raise your heart rate or increase your blood pressure. So theophylline is used to treat moderate to severe asthma, and aminophylline is used just for bronchial asthma. And then our last slide is our immunosuppressant drugs. They suppress the immune response, so they're often used to treat organ transplant rejection. So they're actually given to prevent organ transplant rejection. So they usually put them on there, but if there is a rejection, they would just up these. And they're often used to treat autoimmune conditions. So your traditional treatment for autoimmune conditions is to suppress the immune system. They tend to target cell-mediated immunity because a lot of autoimmune processes and transplant rejection is a cell-mediated process. So it targets your T cells, cytotoxic T cells and stuff. So cyclosporine inhibits interleukin-2. Interleukin-2 normally activates your T cells, so it prevents activation of your T cells. Mycophenolic acid is used in solid organ transplants, so let's think of a kidney transplant, for example, and inhibits DNA nucleotide synthesis. Sirolimus is used in renal transplants and inhibits T cells. Tacrolimus is used in graft versus host disease prevention. So graft versus host disease is when the what is transplanted is an immune system, so it's a bone marrow transplant, and the risk is that the immune system figures out that it's in a foreign body and it attacks the entire body as foreign, and so that leads to graft versus host disease because you have a foreign immune system in the host. And methotrexate is a folic acid antagonist that mimics DNA nucleotides. This one for sure is used in autoimmune conditions. I believe some of the treatments are for lupus, but I know for sure for rheumatoid arthritis it can be used. And that is your last slide. Thank you for your kind attention, and I hope you have a wonderful day.